Hello everybody, welcome to Dental XP. This is Dr. David Wong coming to you all from Tulsa, Oklahoma. I'm going to do a short presentation for you all today regarding soft tissue grafting around dental implants. For this patient, I want to introduce to you, her name is Katie. She presented to our office on an emergency basis because she was unhappy with her existing provisional restorations that are currently restoring number 9 and number 10, which are both dental implants. Now, her story was that she had number 9 replaced initially with a single immediately extracted immediate implantation implant, which failed due to accidentally making contact with tooth number 10, which was a natural tooth. She ultimately lost both number 9 and number 10 and had to undergo numerous augmentations with her oral surgeon. This was her result, and what ended up happening is she lost quite a bit of soft tissue around her implants, and subsequently she was unhappy with both her provisionals, which soon lost her confidence in the final restoration. So what she wanted us to do for her was to augment the areas of number 9 and number 10. The purpose of it was to eventually, hopefully, even the gingival margins of the implant number 9 with the gingival margin of the natural tooth number 8. And then her, the more daunting task for her and her more challenging request was to try to rebuild the papilla between number 8 and number 9 and number 9 and number 10. So looks like we've gotten started here. So the type of graft that we chose for her, and there's a bunch of different ways that we could have done this, but the type of graft that we chose at the time, this is about 6 years ago now at this point, what we chose was the VIP CT graft, which stands for the vascularized interpositional connective tissue graft. There's several names for it, but this is the name that I've always called it. As far as what we're doing here, what it is, it's basically a pedicle autogenous graft. The pedicle is coming from the palate, and basically what we're going to do is harvest a nice connective tissue graft, subepithelial connective tissue graft from the palate, but we're not going to sever the blood supply. We're actually going to leave it intact, hence the pedicle, and we're merely going to flip that connective tissue graft over the recipient beds of number 9 and number 10, leaving that blood supply. Now, the thought process behind all this is not only rapid healing, but the thought process behind this is that by leaving the pedicle, keeping the blood supply intact, we get less shrinkage. We can augment the soft tissue a little bit more than we could than if we did a free type graft. So what I'm doing here is a pretty simple procedure once you get used to it. What we're doing here is getting a number 15 blade, just your basic scalpel, and what I'm doing is making a parallel incision. Beginning from about the distal of the first molar, and we're basically following a line parallel to the free gingival margins of all the adjacent teeth. As we're following around the palate, we make this incision about 3 millimeters away from the free gingival margins, and we're just following the circular shape of the palate until I go almost about half a tooth or a tooth past the implant number 9. Now, as this unfolds, you'll see why we do this. So my first initial incision, once again, is just made 3 millimeters apical to the free gingival margins, beginning from the distal of the first molar, following the free gingival margins all the way around until we get to about the middle of tooth number 8, or the distal of tooth number 8. Our follow-up incision here, we're basically trying to separate the surface epithelium from the underlying connective tissue bed. Ultimately, what I'm aiming for is a graft that's approximately 2 millimeters thick, Is probably what we end up with. But we want it as thick as possible in this case because we're trying to um, obtain as much volume as we can in that side of number 9, number 10, uh, mostly number 9 actually. So what we're doing is just sharp dissection. The important part here is we're trying not to perforate the flap. Sometimes this happens. It's very challenging for some patients, depending on their anatomy. As we all know, there are different gingival thicknesses and densities and such, to where sometimes a perforation does occur. I would say most commonly, if we're going to perforate the flap, it commonly occurs in the anterior palate, where there's a rugae present. Sometimes the depth of the rugae get underneath to where we do perforate that whenever we're sharply dissecting. Next thing you're going to see here, we're just using a simple cotton plier to peel back that primary flap, as you can see here, and then we're just going to continue our dissection. And what we're trying to do is once again, we're trying to get as large graft as we can. So once we have our primary flap back, at this point what we're doing is now we're making a separate incision going all the way until we contact the bone. What we're doing is just trying to contact the bone because ultimately what we're going to do is separate the connective tissue bed from the palatal bone, and we'll keep the base of the blood supply apical to the number 8 and number 9 area. Whenever we're doing this procedure, it's really important to have several sharp number 15s out. Anytime you make contact with the bone like we are here, they get dull rather rapidly. You'll notice here, as we're trying to record this and as I'm trying to keep my scalpel handle out of the view of our viewers, you'll notice that there's not a whole lot of bleeding. One of the things that we often do is inject the site locally with 2% lidocaine with 1 to 50,000 epinephrine. That helps a lot. Obviously, strong suction helps as well. Whenever your assistants are helping you with this, kind of like mine is here, it's really helpful for them to keep the suction at the posterior side of the graft to allow gravity to just basically allow the blood flow into the suction tip. So here what we're doing is just once again outlining our incision into that connective tissue bed now. And here, once that outline has been made, what I like to do is rather than sharply dissect the connective tissue, I like to blunt dissect. So what we're doing here, and I apologize for the moving camera, we don't have it mounted. It's actually just one of my other assistants holding the camera. But we switch over from a sharp dissection for the primary flap to a blunt dissection to separate the connective tissue from the palatal bone. So here we're using a combination of a number 1 Woodson, which is a plastic instrument, and also a Pritchard elevator here to separate that connective tissue from the palatal bone. Now, keep in mind we're only separating it, and it'll be fully separated from the posterior part of the mouth next to the number 14 site, moving anteriorly towards the canine. But as we get closer to the central incisor, the base of the connective tissue apical to the central incisors, number 8, number 9, the base of the connective tissue will still be connected with the underlying bone. And this is important, once again, to maintain that excellent blood supply for this type of a graft. Sometimes it takes several passes with the number 15 blade to free up that connective tissue, but as we're seeing here, we're basically just tugging and pulling with our tissue pliers or just your basic cotton pliers. You're pulling with that while also sharply dissecting and freeing up that connective tissue graft from the palate. Now, one thing about patient's anatomy we all need to be aware of, the reason that I choose to blunt dissect the connective tissue is that there's a large percentage of people who have palatal tubercles and tori that we're not aware of. That depending on whatever skull study you're reading, this percentage can be anywhere from 25 to 40%. So obviously this is dictated a lot of times by race and geography, but just let it be known that palatal tubercles and tori and things like that often make it complicated to obtain a nice piece of connective tissue. So when possible, I try to blunt dissect the connective tissue to avoid perforations and unintentionally separating the graft from the palate. I'll also note that deeper palates are much easier to perform this procedure on than shallower palates. Also be aware that not all palates are created equal as far as the quality of the tissue. Some palatal tissue, like this one, is more ideal, where you're able to obtain some nice dense connective tissue. But sometimes, as we know, patients have really fatty or glandular type palatal tissue, so that the quality can vary. So what I just showed you was how we basically flip that connective tissue graft over the recipient bed, or the upcoming recipient bed, and it's still intact. So at this point, I just leave the palatal graft alone, and now we work on the recipient bed. For the recipient site, even though I'm not thrilled about the papilla between number 8 and 9, I'm still not ready to give up on it entirely. So what we do is we basically make a vertical incision that is somewhat papilla sparing. It doesn't spare the whole papilla, but we're just basically making an incision down the center of the papilla between number 8 and the implant number 9, as you can see here. So here, what I've chosen to do is since the donor site involved an incision that was made palatally towards the palatal side of the implant, we went ahead with that and utilized that as our most coronal incision for the recipient bed preparation. So here, with that number 1 Woodson instrument, we're basically just once again just reflecting a full thickness flap here, just going all the way to the bone so we can get a full view of the implant. Some people would probably choose to reflect a partial thickness flap here. Once again, that's fine. But I chose a full thickness approach in this situation for me because it's simpler and safer. It's better soft tissue management for me because we decrease the chances of perforating the flap. It also allows us to evaluate the implant for exposed threads or thin bone and things like that as well. So that's just where this is very helpful to do it this way. Now, because Katie has had so many surgeries before, she ultimately ended up with not only a particulate type ridge augmentation with a membrane, she also ended up with a block graft utilizing the rambus of her mandible. So she's had several surgeries, and as you can see here, because of that, we have quite a bit of scarring. So trying to, and you can actually still see some of the particulate graft that was left there. But as a result of that, it's hard sometimes to get the facial tissue fully reflected. So in this situation, we use a combination of some sharp dissection to release some of the periosteal fibers, and some of the scar tissue fibers as well. So we're basically using a combination of blunt dissection, like we are here with the Pritchard, and the sharp dissection earlier to sever some of the scar formation that's evident. Now we're trying to get full release of the flap so we can close over our soft tissue passively. That's why we're so much attention to detail is taken here. So here we're doing a periosteal release of the facial flap. This is with a fresh number 15 blade. This is just kind of a nice outline for those of you who are not used to releasing flaps. This is the way I like to do it, and I just use a fresh 15. We go right into the periosteum, and basically we're able to test that flap. And then what I do is we just keep making more and more releases on the underbelly of the flap into the connective tissue until we can get not only the palatal flap closed, but also the facial flap, closed as well, very passively, and also in a way that we can maintain the space of the graft and stabilize the graft properly. These are all really, really important qualities of not only soft tissue grafting, but hard tissue grafting as well. So here we are, just more and more periosteal releases here. And yeah, I can't emphasize enough the effect of scar formation here. So it's making it really, really difficult to release this facial flap. See, there's so much tension in there because of all the scar tissue. But the key here is just to be patient and try to have as dry a field of view as possible, so you can evaluate, what scar tissue fibers are holding you up and preventing full passivity of the flap. So once we have that flap released, what I chose to do is we made a slit basically in the center of the VIP graft. And the surgeon that placed the implants, it wasn't done in our office, but the surgeon that placed the implants used a uni abutment from Esthetic, which is from Dentsply, Sirona now. But there's a slit that's made into over the connective tissue graft so that we can basically slide the graft over the Esthetic uni abutment, which is just basically a taller healing abutment. So here we are. We've made the slit. We've slid the graft over that abutment. As you can see here, it also kind of serves as a tenting screw or even a tack. That way the graft is stable and it's maintaining space. So we don't really need to do anything else. We basically just slipped the graft over that abutment. So here we're just basically at this point, all we have to do is put the pieces back together. The huge benefit of the VIP CT graft is that it's actually okay to leave some of it exposed because it's such a highly vascularized graft. It almost never sloughs or anything like that. So just closing it in this manner, even though we have a large perforation from where we from basically where the healing abutment was, it's still not going to compromise the long-term success of this graft. So here we are basically just using interrupted sutures. Here we're using 4-0 vicryl sutures, just an interrupted style, just to close up the facial flap with the palatal flap for now. And then I proceed on later to close the rest of the palate with the same 4-0 vicryl suture, but I just use a continuous baseball style suturing technique. Now, the other challenges of this case, while we're just watching the suturing, is as numerous lectures have talked about here on Dental XP, is that we have two implants next to each other. So trying to create papilla between two implants next to each other is probably the most challenging thing that we can do. But at this point, because of the way Katie walked into our office, there was really no going back at this point. And as you'll see here too, whenever we show you the final radiograph, you'll also notice the apical position of the implants. So whenever she left here, we basically do our best to try to reline her provisional. At 2 weeks, you're going to notice that her palate heals really, really rapidly. That's what it looks like at 2 weeks. And then the facial soft tissue heals pretty well and fast also. You'll notice here that we definitely could have did a better job with the provisional to better contours to shape the tissue better. But at any rate, 2 years later, you can see that we do have a slight crestal bone loss, but you can once again note the apical position of the implants. And now her final restorations at 2 years, we can be very critical of this. We indeed were able to get the free gingival margins of number 8 and number 9 even and relatively symmetrical. You'll notice that we were also able to recreate some papilla between number 9 and number 10. Certainly it's not as large and robust as the papilla between number 7 and number 8, but it's there, and the patient is happy. There are other critiques of the ceramics and the other portions of the final restorations, but as far as the surgery goes, we're very happy with it. The facial tissue of number 9 and number 10 is adequately augmented. You'll notice that it's plenty keratinized and attached. The color match is pretty good. Certainly it's not perfect, and to the trained eyes of our members here, we can probably tell which areas were operated on, but for the most part, we consider this graft a success. So I hope you all enjoyed this short video about the VIP CT graft. Let me know on the message board if you have any questions, and I look forward to your input. Thank you very much.